Hello and welcome to the AOT Pod, an FRCS themed podcast tackling key themes, challenging topics and insightful intellect within otolaryngology, hosted by myself, Livy Kenyon, and my co-host Carla Kumarason, with support from the ENT UK Foundation and Association of Otolaryngologists in Training. Your guide to passing the FRCS starts here as we take you around the country to some of the best and brightest minds our specialty has to offer. So without further ado, let's begin.
Hello, I'm Simon Carr. I'm an ENT registrar in the East Midlands, and I'm here to deliver an episode of the AOT pod. Today's theme is thyrotoxicosis. I'm pleased and privileged to be joined by Mr Peter Conboy, head neck consultant at University Hospitals of Leicester. He graduated with honours from Leicester Medical School in 1994 and has completed higher surgical training in East Midlands and fellowship training in head neck surgery at the world-renowned Princess Margaret Hospital in Toronto, Canada. He is the head neck lead for the MDT for UHL and has won the El Horani Award for Trainers in the Midlands. He's held positions in University Hospitals of Leicester, including Head of Service for ENT Surgery, Medical Lead for Special Surgery, and recently Lead Clinician for Thyroid Cancer. He's been the Regional Representative for Royal College of Surgeons of England and has sat on the National Council for ENT UK. So thank you for joining us. And I've got a few questions about your time doing the exam. So when did you take your exam and what was going on in your life at the time of preparing for it?
Well, firstly, thank you very much for inviting me on this podcast. I took my exam back in 2002. And in terms of my life at the time, I had a 5-year-old and a 1-year-old. So I was trying to juggle sort of home life. I was commuting to and from Nottingham from Leicester, which was probably adding the best part of a couple of hours a day. And I had been in Leicester, transferred to Nottingham 3 months before the exam. And when I arrived, there were two of us about to sit the exam, and one person was far more prepared than I. So I had a high level of anxiety as I approached the examinations. And so, yeah, that was pretty much the state that I was in.
So you've kind of outlined some of the challenges there. It sounds like you'd appreciate a podcast back in the day with that commute. Moving on to the positive, how did you feel when you passed and how did you celebrate?
Well, it was a great sense of relief, actually, in a way, because there was some intrinsic pressure because nobody on the East Midlands training program had not, or everybody had passed the examination, I suppose I should say, in a positive fashion. So fortunately, I was able to add to that. And I think basically it was one of still, as most of us do, wondering what to do with this additional time that suddenly was on my hands from all of the preparation that went into doing the examination. And fortunately, I had a week off afterwards and spent a bit of time with the family.
Lovely. Best thing to do. So let's get into the Viva style questions.
Mm-hmm.
So a 35-year-old female comes to your head neck clinic as an urgent GP referral. The letter reads, enlarged thyroid and feels breathless, query goiter. As she enters a room, you notice diaphoresis. How do you proceed and what is in your differential?
Well, obviously, that letter doesn't have an awful lot of information in it, but based on the indication of something with the thyroid and the very sweaty person that's in front of me, I think that I'm going to be dealing with a likely case of thyrotoxicosis. And with that, I think any history should be focused on the thyroid side of things and some of the systemic features that can go with an overactive thyroid. So specifically, the history should be a head and neck surgery history with the endocrine element, and the head and neck surgery history, and particularly with regards to the thyroid, would be how long has it been there for, what's the rate of progression, what has been the impact? So are there problems with swallow? Are there problems with compression? Has there been any change in the voice? And then going on from that in thyroid in general, you'd want to know about background to whether or not there was any family history of thyroid disease, and in particular, whether there'd been any history of family thyroid cancer, and I suppose any exposure to possible radiation in the past as well. Because we're dealing with an endocrine phenomenon, there are associations with autoimmune diseases. And so I'd want to inquire about family history of autoimmune disease as well. And then specifically on the subject of an overactive thyroid, it would be symptoms first. So you'd be looking for palpitations, whether there's a history of that, unexplained weight loss, maybe sleep disturbance because of that, excess sweating we've already touched upon, which is clearly here in front of us. And then probably importantly, because we're dealing with a 35-year-old woman in the context of acute thyroid presentation, whether or not she could be pregnant. So that would be the history. And then the examination would be directed towards the thyroid itself. So what is the size of the thyroid gland? Is it uniformly enlarged, or are there multiple nodules which might give a different direction of travel? And then with regards to associated things like lymph nodes, we'd want to do a flexible nasal endoscopic examination of the larynx just to assess the vocal cord movements. And moving on from that, I would then want to address potential thyroid signs. And I'm thinking here of looking for excess tremor, feeling for the pulse. Is it irregular? Because atrial fibrillation can be a sign of thyrotoxicosis. And finally, I would want to look at the eyes. Lid lag is a sign of thyrotoxicosis, but there could also be protrusion or exophthalmos. And in that situation, that is really something that would point towards the diagnosis of Graves' disease. That's the examination. Then the immediate investigations, I would think, are prompt blood investigations. We're looking at thyroid function in particular. So these would be TSH, T4 and T3. And then, of course, I'd want to look at the antibody screening. So a thyroid receptor antibody testing. In this day and age, it would be thyroid stimulating immunoglobulins, which would be the test of choice. But there are other antibodies to include as well. So thyroid peroxidase antibodies as well as antithyroglobulin. And then finally, of course, with the fact that we're dealing with an enlarged thyroid, I'd want to schedule an ultrasound assessment, and hopefully we'd have access in the clinic in real time to be able to do that. I mean, the other thing to touch upon is if they have acute eye signs, then we might have to enroll the ophthalmologist for an acute assessment to make sure that the eyes were okay. There was no signs of corneal compromise. And of course, we're dealing with an acute endocrine situation. So my inclination would be in an uncontrolled thyroid patient, I'd want to get the endocrine team involved at an early stage.
Thank you. So you've mentioned thyroid disorders. Please could you define thyroiditis and differentiate from thyrotoxicosis and hypothyroidism, and then list some major causes?
Okay, well, thyroiditis is inflammation of a thyroid gland, and that can be due to many causes, whereas hypothyroidism, strictly speaking, is a biochemical diagnosis. So that involves blood testing, and that would be abnormal blood tests due to increased thyroid hormone production and secretion by the gland itself. Thyrotoxicosis then is the acute manifestation systemically of the overactive or hypothyroidism. And then, well, the commonest cause would be Graves' disease, a disease that was first described by an Anglo-Irish physician, Robert Graves, in the 1830s, actually. I like my history. And he described a case of overactive thyroid and exophthalmos. So it was those two things together. But in addition to Graves' disease, you can have toxic multinodular thyroid disease. You can have chronic lymphocytic infiltration of the thyroid, which is also called Hashimoto's thyroiditis. There are subacute presentations, subacute lymphocytic presentations, which can occur after delivery, so postpartum. And then you can have a granulomatous thyroiditis, which is also called de Quervain's thyroiditis. There is a fibrous version with the horrible Rydell's thyroiditis. Anybody who's come across that as a surgeon hates that condition. And finally, there are certain drugs, and in particular, there's a drug, amiodarone, that can cause thyrotoxicosis.
Great, thank you. And thank you for clarifying those synonymous eponyms. So the anti-thyroid receptor antibodies you've sent has come back as 1.8 international units per litre. Please give your diagnosis, explaining underlying pathophysiology and the overview of your management.
Well, a result of 1.8 is basically pathognomonic for Graves' disease. Up to about 1.5, the results can be equivocal, but beyond that, it's pretty compelling. And this is a test which is specific for Graves' disease indeed. With modern assays, the sensitivity is probably approaching 97%, and I think the sensitivity is 99%. So the thyroid stimulating immunoglobulin testing is the diagnosis here. And this is a hypersensitivity reaction that's taking place, a type 2 hypersensitivity, where we have basically stimulation by binding with the thyroid stimulating hormone receptor, which is then causing increased production of T4 and T3.
Thank you. And your management, please.
I think it's important to remember that we're dealing with a disease which is an endocrine disease, Obviously, it's sort of overlapping with ENT and also with eyes. So it has to be a multidisciplinary condition. And when it comes to the surgery, then there are endocrine surgeons as well as head and neck surgeons that deal with this. But I think it's important not to minimize the really important contribution from our endocrinology and ophthalmology colleagues. And in terms of management, then I think you can probably broadly break this down into the management of acute onset of the first diagnosis. Typically, this is managed with antithyroid drugs, but there are roles for radioiodine treatment, which is normally supervised through the endocrine side of things. And also, there are potentially roles in certain situations for acute surgical management, although I would see that as a very much a third thing in this particular thing. And then the secondary point is really about the having controlled the disease, what is definitive management, and whether you remain on antithyroid drugs or whether to do a definitive management, including either radioactive iodine or surgical management.
Thank you. Would you be able to mention any specific considerations around the use of radioactive iodine, particularly pertinent to this patient?
Well, I think there's two things. We haven't established whether or not this patient is pregnant, but clearly that's a really important thing because that would be an absolute contraindication. Indeed, if the patient intends to try and get pregnant within the next 6 months, that would also be a contraindication. So I think in those set of circumstances, we would take that off the table straight away, and we would be looking primarily at initially probably a drug-related management. In the situation of pregnancy, if they were in the first trimester, then the go-to drug would be propylthiouracil, PTU, because of the risks of carbimazole in the first trimester with fetal abnormalities. So no antithyroid drug is without its problems. Both of them have a risk of neutropenia, and with PTU, there's also a risk of hepatic problems. So acute monitoring and management of that would normally be under the supervision of both the endocrinologists and the obstetricians. But the other risk, an important risk with carbimazole, would be agranulocytosis, or which, albeit very rare, is a catastrophic condition.
Thank you. So you've referred your patient to the endocrinology consultant for management with antithyroid drugs, and unfortunately they've contacted you back and informed you they haven't responded to the antithyroid drugs. Please could you discuss your considerations around surgery in Graves' disease?
Thank you. I think the first thing I'd like to explore is if they're not pregnant and they have, whether or not they've had an appropriate discussion with the endocrinologist about the potential for radioactive iodine. I know I'm not addressing the direct answer to your question, but I just want to put that in. One of the things I'll do in the clinic is just explore whether I feel that conversation has been had. But assuming that it has, then we're looking at surgery which effectively involves a likely total thyroidectomy. And I have to say that it is surgery which has higher risks. We're dealing with a hypervascular organ. Certainly, what you'd want to do is to make sure that this patient has been as optimized as possible from a medical point of view. So we're looking at ensuring that they're potentially needing beta blockade to slow down the heart rate, make sure that if they have eye disease, we may have to consider the possibility of steroid cover because it can be a worsening of that with surgery itself. And then, of course, the discussion with the patient really is around complications of thyroid surgery with some little nuances. So they will need lifelong levothyroxine replacement afterwards. There is a higher rate of hypocalcemia post-operatively. I think when we've done local audits, the rate is in excess of 30% in the acute setting for a Graves' disease patient, and therefore it's also a sort of higher rate of long-term need for vitamin D and calcium supplementation thereafter. Of course, in a bloody and vascular organ, there's probably a higher rate of potential injury to the recurrent laryngeal nerves as well. So all of the above apply. I'd want to make sure that the patient had been properly evaluated by ultrasound before as well, because there is a higher incidence of coincidental thyroid cancers in patients who have cold nodules in Graves' disease. And it's not unusual for us to receive histopathology reports post-operatively where we find small foci of differentiated thyroid cancers. One of the hard things about that is then having a discussion with the patient about the relevance or not, because obviously that's a secondary thing to have to pick up with, but it's something that we need to bear in mind, and that might actually drive the discussion towards surgical management rather than radioactive iodine in the first place.
Thank you. So you've mentioned about beta blockade prior to surgery. Are there any other adjuncts you would consider preoperatively?
Interestingly enough, one of the things that I would have strongly been in favour of, certainly 20 years ago when I was doing this sort of surgery, was the consideration of Lugol's iodine. It's a solution of iodine with potassium iodide, which helps to sate the thyroid gland and therefore reduce the toxicity and also some of the bleeding around the time of surgery. It has to be given within a couple of weeks of the surgery itself. So the timing is important, and therefore it's really critical to bring somebody in who's been on it and not cancel them on the day, which in this day and age it can be a challenge, but it's important because it's sort of one shot at this. There is anecdotal evidence that this reduces the bleeding at the time of surgery. I think that the information from reviews is a bit more conflicting now as to whether that's true or not, but certainly there's nothing to be lost in somebody who's poorly controlled to try and do everything you can to help both with the surgery itself and also reduce the risk of thyroid storm or one of the other sort of very rare complications that go with it.
Okay. So can you tell us more about thyroid storm?
Well, it is fortunately a rare thing. It's a sort of multi-system problem presenting with hypothermia, hypertension, and for general systemic collapse. And so this is a condition which is an absolute emergency, will involve often input from endocrine, from cardiology, from intensive care, from anesthesia and surgery itself as well. And so typically what we've got to do is try and cool the patient, ensure that they're appropriately fluid resuscitated, control their heart rate with beta blockade. There's a role for steroids here. The aim is to really try and bring this set of symptoms and signs under control to allow then a timely surgical intervention to bring things back to some kind of normality.
Okay, thank you. Can you let me know some other precipitants of thyrotoxicosis and thyroid storm?
Absolutely. Yeah, so if somebody's taking too much thyroxine, which, sort of is hard to believe, but it is possible. But things like contrast studies, that involves delivery of a large amount of iodine-based contrast. Other causes of, anything that can cause trauma, including other surgeries, can induce this in poorly controlled patients. Patients who are, well, pregnancy and childbirth are recognized as potential causes. Infections can cause it. And then things like just a high emotional stress state have been recognized, as well as things like diabetic ketoacidosis.
Okay, thank you. So post-operatively, you mentioned about risk of hypocalcemia. Please would you
Yeah.
let us know your management of hypocalcemia?
Well, absolutely. So we have local guidelines. I think that the British Association of Endocrine and Thyroid Surgeons also have guidelines. But essentially, anybody who is symptomatic, which probably means that their adjusted calcium is less than 2, or if their calcium is below 1.8, then that's considered to be an emergency because of the pending potential for some sort of cardiac arrhythmia. And so in that situation, I would want to administer some calcium gluconate, and typically this has to be done under cardiac monitoring conditions. I'd give 10 mils of 10% calcium gluconate in 100 mils, and that would be given over an hour. And then in the following 24 hours, I'd administer 40 mils of the 10% calcium gluconate in 1 litre. Again, as I say, in constant monitoring just to assess, to be reassured about the heart. And then, of course, what we're aiming to do is just bide that time, but we then have to introduce oral calcium. Calvive is the drug that we would use in Leicester. And also, obviously, we're at a stage now where the endocrine team would be invited to give an opinion as to what other adjuncts are needed.
Thank you. Just to conclude, you mentioned about thyroid eye disease and the considerations around surgery there.
Mhm.
Please would you elaborate on that?
Well, thyroid eye disease, essentially, as we've said already, is it's not particularly well understood actually, because thyroid eye disease can present sometimes before the thyrotoxicosis, but when that happens, often thyrotoxicosis does follow. But because of that way round, the exact mechanism of what's happening to the fat and the muscles within the orbits is not altogether unclear. But the result, however, is an attack on those structures with gross swelling. And the swelling of the muscles in particular can compress the optic nerve. And we've already described the other thing, which is the exophthalmos itself. So in terms of that management, I would want to basically have, again, a multidisciplinary approach to this. I think it's involving the ophthalmologist, but ENT does have a role to play because we have rhinologists that can perform orbital decompression surgery. And the idea is to allow more space, but preserve an inferior buttress really to prevent diplopia, which is obviously a potential complication from this. There are European guidelines, a European group on the orbital complications of Graves' disease, and I'd want to follow those. I think the latest ones came out in 2021. But in essence, the quick win is if somebody's a smoker, because we know that smoking is a compounding factor for this, the smoking cessation is really important. The idea is obviously to try and acutely manage with steroids. There's a medical intervention there. I've talked already at the introductory thing about making sure that we're looking after the cornea in terms of making sure that we're not going to get abrasions because of that exophthalmos and avoiding the keratopathy that goes with that. So eye drops, for example, would be a simple but important consideration in all of this. And then the tricky thing about eye disease is what strategies should you adopt? In days gone by, definitive management, radioactive iodine was considered an absolute contraindication because it was thought to exacerbate the eye disease. But actually, it's been realized that with steroid cover, it's actually not unreasonable to consider radioactive iodine, particularly in mild or moderate situations. Potentially in severe and uncontrolled disease, you might lean more towards surgery. But I think it's recognized now that radioactive iodine is no longer an absolute contraindication in that situation.
Fantastic. Thank you very much. Thank you for sharing all your wisdom on those questions. I'm going to summarize some key points. So, ear, nose, and throat surgeons must be attentive to thyroid status in their patients. An understanding of diagnosis and management of this will aid our interaction with our endocrine colleagues. Thyroid surgery in Graves' disease comes with a heightened risk and additional perioperative considerations. And uncontrolled Graves' thyrotoxicosis and thyroid storm are life-threatening conditions which require careful multidisciplinary management. For management of thyroid disorders, there are several relevant guidelines, including NICE guidelines, BEATS guidelines, and UGOGO guidelines, and these are useful to be aware of for the examination. Also, for further listening about thyroid disorders, go to Series 1, where there's an episode regarding multinodular goiter.
Thank you, Simon and Mr Conboy, for this wonderful episode. Thank you to our listeners, and we hope you enjoyed this episode of the AOT Pod. Be sure to check out our other topics and give us a like and subscribe to get notified when new episodes become available. For more educational resources, visit the AOT website aotent.org and our YouTube channel AOTENT Education, and make sure you come to our amazing inspirational annual conference where there are also prizes for presentations up for grabs. See you next time!